First, I'd like to thank for the invitation to this marvelous summit symposium. And my talk is about perspectives in patient selection, future in interventional cardiology, PCI and LAAO. I would like to come back to the basics first. You all know the Chatz-Vask score and the Hasplit score with a bleeding risk. And if you look in detail on these scores, you can see that most of the points are appearing in both, especially hypertension, age, stroke, and TIA. They are all in both scores present. And there is another problem. Taking other drugs as well means clopidogrel or aspirin is another risk factor for bleeding. And there's another point. Many of these patients have concomitant diseases like acute coronary syndromes, coronary artery disease with stent implantation, carotid artery disease or peripheral artery disease. And these patients should be better treated with aspirin or clopidogrel. So I'd like to make a first statement. Most of the patients with a strong indication for anticoagulation have a high risk of bleeding, and many of them have diseases that are better treated with antiplatelet therapy. Now let's have a look at different studies. If you have patients on coumadin therapy appearing with a STEMI, and they are treated by PCI, you can see there is a higher bleeding risk in these patients under coumadin therapy, 17% versus 10%. Even with the INR below 2, it's 16% versus 10%. And with GPI use, it's also higher. Only with radial access and bivalirudin use, you could reduce bleeding risk and mortality. If you look at the worst